Hello, everybody. My name is Peter Roeleveld. I'm a pediatric intensivist from Leiden in the Netherlands. And I welcome you to another webinar from EuroELSO with a pediatric theme today. We're going to be talking about anticoagulation in ECMO in children and in neonates. And we have a few excellent speakers. Can I have the next slide, please? Yes. So we have three speakers. We are starting off with Laurance Lequier from Edmonton in Canada, who's a very well-known ECMO specialist and enthusiast whose main interests are neurologic outcomes and anticoagulation. He's been on the, or still is on the EuroELSO anticoagulation task force, so we're very happy to have him. Then we have Ariane Willems, who's a colleague and friend of mine from Leiden, was trained in Belgium and was also an associate professor of pediatrics in Brussels, has experience also in Canada, so it's a very Canadian team today. And her interests are in transfusion and also anticoagulation and ECMO. And then after these two talks, we will have a panel, and Gail Annich will join us. And Gail is a well-known professor of pediatrics from Toronto, pediatric intensivist, who has also had a lot of experience with ECMO from the University of Michigan, but is now back in Toronto, and her main focus is on coagulation. So these are three people that we can learn a lot from. So let's start off with the program for today. But before we do so, can I have the next slide? Yes, that's the one I want. Before we start, I want to remind everybody of the virtual conference in May, which is from the 5th to the 7th of May. I'll show you a slide at the end of, yes, thank you very much, Victoria. I'm sorry for the confusion. So I want to remind you all, this topic that we're talking about today is one of the many topics we will be talking about at the virtual conference. This is a lead up to a very nice session on anticoagulation. So please, if you're interested in ECMO, join us at the EuroELSO conference. Now, for today, we have a program, like I said, with two speakers and then a panel discussion. During this, the two talks, you can send in questions via the chat, and then I will collect them and then relay those questions to the speakers at the end of the two talks. So please send in your questions during the talks, after the talks, and I will try and keep up and relay them to the speakers. So enough from me. Let's start off with the first speaker, Laurance, who is going to talk to us about anticoagulation monitoring on ECMO. He's going to give us an overview of the current modalities. And Laurance, thank you for being here, all the way from Canada, and the floor is yours.
Great, thanks. Thanks, Peter, for the introduction, and thank you for the invitation to come and speak. It's been terrific here to have that. I'm just having trouble seeing my own slides here. Sorry, Victoria, on my own computer, I only see myself. I'm not sure why. Because earlier.
Okay, so just try to enter or to exit from full screen view and to restart your presentation. So then you should be able to see it again.
There.
We can stop the.
Can you see it now?
We can see your presentation.
I can see it now. Perfect. Great. Thanks, everybody. Sorry. So yes, thanks for the invitation. And it's my favorite topic to talk about. And I think it's a favorite topic, I think, for people everywhere doing ECMO to talk about. It's very challenging doing ECLS. And I think whenever we get together at meetings, whenever I teach courses, the biggest question I get asked is about anticoagulation. And I think it's because it's so hard for us to deliver this incredible amount of anticoagulation to these incredibly sick patients, and to have to deal with all these complications of bleeding, number one, and thrombosis, number two, and try to get good outcomes. And I think we're getting better at all of them. And I think it's because of these kind of sessions. And so I hope that there'll be something that everybody can take away from these sessions to back to where they go. And certainly in the question and answers, it's great discussion. So I'm looking forward to it. So I'll just review quickly the use of some of the standard monitors for heparin anticoagulation that we have been using for a number of years, including the ACT, the APTT, the TEG, and the ROTEM. And there are some certainly advantages to each one and some disadvantages to each one of those, as we'll go through. And then there's been an increasingly number of studies that are published looking at the way we use those novel monitoring techniques and what they're showing us. And I'm going to show you some of that. Now, one of the other novel techniques, novel monitors, is the anti-10A, which I'm going to try not to talk about too much, except for maybe a tiny bit at the end, because Ariane is going to be doing an excellent job of discussing that after this session. I do. My disclosure is that I do get travel bursaries to teach courses in South America from McKay, and of course, all of us will be discussing non-FDA approved use of medications. Okay, so just to sort of, as a way of a reminder, a way of an introduction, we're mainly going to be talking about these novel monitors for the use of monitoring unfractionated heparin delivery. We're not going to be talking about anything by way of direct thrombin inhibitors. Not much time for that on this session, but certainly something for another session. And when we dose and monitor unfractionated heparin, it's a fairly standard approach, but I think it's fairly different. So most of us would use a standard load, 50 to 100 units per kilo, when we initiate ECLS for our cardiac ECMO and respiratory ECMO patients. We're usually on somewhere between about 10, 20, 30 units per kilo per hour, maybe 40 units per kilo per hour. I think with the equipment that's available now, the actual amount per kilo that we're on is significantly less than it used to be 10, 20, 30 years ago. And we have a number of monitoring techniques, and put them there on the side, whether that be the ACT, the APTT, a number of TEG variables, and the anti-10A that, again, Ariane is going to discuss about. And so when we put the first anticoagulation guideline on the EuroELSO website in 2014, those are the kind of things that we put on there. That was updated in 2017, as you see on the bottom. And it's basically the same information that we included in the chapter in the latest edition of the EuroELSO ECLS Red Book, the textbook, the 5th edition. And so I'm hoping that you guys have probably all seen that and read that. And so most of this is not new to you, but that doesn't make it any easier. Okay, so I put this slide in because before we get to the actual monitors, because I think this puts in perspective why this is so important. And so we know that, you know, as I said, we've all experienced complications of bleeding and certainly complications of thrombus during the course of doing ECLS with anticoagulation. And there's now been more and more studies that have confirmed what we've always thought, and what we've seen on the EuroELSO database is that bleeding complications lead to poor outcomes. And so this is a great study. Heidi Dalton, with over 8 centers, Capricorn centers in the United States, showed that bleeding events are significantly associated with mortality, and that you lose blood by bleeding, patient bleeding, as well as blood loss from other ways. And one of the other ways is blood testing. And in the bottom right-hand corner, you can see a different study showing that when you have all the blood tests that add up during the course of the day and the week and the month, that there's a significant amount of blood loss from those bloodletting sort of monitors. And one study showed that depending on the type of monitoring you use, if you're using those monitors more efficiently and less, that there's less blood loss over the course of an ECMO run. And so the less blood loss, the less blood replacement, and certainly the better outcomes. Okay, so let's review then the monitors that we talked about. So as I said, there's the ACT, activated clotting time, which was really the workhorse of ECLS for decades. And I think it's a terrific test. it's an activated test. It's basically a bleeding time. So it's just like when you're in your high school or science class and you take a little drop of blood on a test tube and you wait till it sort of coagulates into blood and look at it under the microscope. Well, basically we don't wait for 9 or 10 minutes for a bleeding time. They made an activated bleeding time, and so basically that's putting glass dust in a tube. The glass dust activates the bleeding process, the coagulation process, and the bleeding time is reduced from 9 minutes down to about 150 to 100 to 200 seconds. So it's a significantly reduced bleeding time. And the ACT measures both the intrinsic and common pathways of whole blood with all the cellular elements in place. So it's a whole blood test. It's a point of care test. It's available 24/7 and it's inexpensive. And so I think this is why it's really been a terrific test for ECLS and BAD and things like that, because of how available it is. And normally whenever using ECLS applications, we would say, well, let's keep the ACT about double what it normally should be. So a normal ACT, a normal clotting time of a patient without heparin is about 90 to 100 seconds. So the decision was made, okay, let's just double that. 180 to 200 seconds is a standard sort of activated clotting time range. But the accuracy is altered in a number of different ways. If you have coagulopathy, if you have platelet dysfunction, which certainly we see significantly in ICU patients, if your sample is hemodiluted, or if it's a different temperature, if you take it from a different site or a different sample amount of blood in the sample, certainly it's much more unreliable in immature patients, so infants, and it's the studies on the right-hand side show here, looking at in Columbus, looking at taking blood from babies and seeing that at different times and at different sites you get different results, and also from different monitoring devices, ACT monitoring devices. So very, very imperfect test. The activated partial thromboplastin time, the APTT we say, so this is an activated test as well, but it's a plasma test, it's not a whole blood test. The activator in this case is actually phospholipid, and phospholipid comes from rabbit brain tissue. So you take rabbit brain tissue, you add it to the test tube, you spin the blood to get the plasma, you take the plasma, which has your anticoagulant in there, and you put that all together. And what this measures is the amount of prothrombin and fibrinogen conversion, but again, without cellular components involved. And in non-ECLS applications in adults, it's shown that if you have an APTT of around 50 to 80 seconds, which is about 1.5 to 2.5 times of normal, that correlates to a heparin level of about 0.2 to 0.4 units per mil. And this is done by protamine titration in adults. And this is a great test to monitor the delivery of heparin anticoagulation for things like, people with DVTs and things like that. Certainly APTT is more reliable than ACT at delineating low and moderate levels of anticoagulation in adult patients in intensive care on unfractionated heparin. And this makes it, I think, a really good test for extracorporeal devices. Makes it a good test for ECMO, for CRT, because we're looking at low to moderate dosing, which is what we typically use in these patients. It's not a good test for really high doses like cardiopulmonary bypass. And the next thing is there are point of care tests that are now available, and you're going to see a study of that coming up, that are getting better and better. So that's making it more available. The next test is something called a TAG, a thromboelastogram TAG. This has been around for over 50 years. Those of you that are working in cardiac centers know that they use these in the cardiac OR to monitor and sort of deliver anticoagulation, heparin anticoagulation. And what this test does is it's whole blood test. It measures the viscoelastic properties of blood. And so basically you have blood in a cup and a pin sits in the middle and vibrates. And as the clot starts to form to the pin pulls, the clot gets stronger and stronger, and the pull gets stronger, and it creates a force. And so basically we examine a few different things. We first have the reaction time, which is the effect of heparin, the amount of heparin that you have in your sample. And so the more heparin in your sample, the longer the reaction time before the blood first starts to clot. Then the next thing is the slope of the curve that's created is affected by the clotting factors that we have available. Then at the very top, you have your maximum amplitude of the curve, and this is significantly affected by platelet function. And then finally, the test stays in the tubule for another 60 minutes, as fibrinolysis takes care of and the clot starts to be resorbed. And so then you see the Cartman curve in the top and the actual curve on the bottom, a really terrific example of the TEG. The next thing we're going to look at is the thromboelastometry, which is done more similar sample, but in that it's a whole blood test. It measures whole blood kinetics. It's also a global assessment of hemostasis like the TEG was, but it's done in a slightly different way. If you see in the picture, it's done by light refraction. And so the blood still sits in the cup like it did before, and the pin sits in the middle, but it rotates. And the pin doesn't vibrate, it rotates. And as it rotates, light comes through on the side. And as the blood starts to clot, the refraction of light is changed and you get a reading. And you can measure a number of different factors, variables, just like you can on the TEG. There's the XTEM, which is insensitive to heparin, the INTEM, which is sensitive to heparin. They have a HepTEM, which basically adds heparinase like you can in the TEG with a second cup, and then an APTEM, which looks at aprotein and fibrinolysis inhibition. So there have been one study that showed that has poor correlation of INTEM CT and APTT, and that may result in slightly over-escalation as you sort of titrate heparin, but certainly there needs to be more studies, I believe, for us to compare. There, as I said, there's a great study now showing the APTT point of care test. This is Tim Mall's group in Pittsburgh looking at 170 patients. And what they showed was there's really no correlation, as we're seeing in study after study after study, of the ACT to the heparin dose, but that there's a really okay correlation of the APTT done by the lab and the APTT done by point of care testing to the heparin dose. That for whatever reason, the cardiac patients had a better correlation than the respiratory patients, and that the older patients had better correlation than the younger patients. They also showed that there was a decent correlation if you compare the lab APTT to the one point of care. Another test showing that a neonatal test, again, like the first one I showed you, this is patients looking at linear correlations. And what they showed was that there was good correlation with both ACT and PTT to anti-10A within the patients, but between the patients, the correlation changed. And so when you look between patients, the ACT actually had a negative correlation, as you see on the top, and the APTT directly correlated on the bottom with anti-10A. So a good correlation of those tests. You're going to hear more about the anti-10A next. And then there's a couple recent studies that I think are perfect for our webinar discussion. The first one here from 6 months ago in Seattle, where they did an in vitro and in vivo study of 47 patients. They measured APTT, PT, ACT, and anti-10A. They did Pearson correlations, looking at polynomial regressions of comparing factors of different anticoagulation. And what they showed was, what we've seen again and again, the ACT is not reliable. The ACT is too imprecise, but that the anti-10A is the most specific measure of heparin anticoagulation. But in patients where it is impossible to use anti-10A, the APTT is the best choice, like in patients where we have significant hemolysis or hyperbilirubinemia. The most recent study just came out last month from Boston. This is where they're looking just at cardiac patients and TEG and bleeding risk, and they looked at different associations of bleeding to all the measures that we're talking about, APTT, anti-10A, and TEG variables. And they had 40 patients, 25 of those 40 patients, so over half of them had bleeding events, and they correlated the predictors of bleeding to all the variables. And what they found, the strongest predictor was TEG variables. And so the highest risk of bleeding was when your MA, maximum amplitude of your TEG curve, is less than 55 millimeters and your reaction time is greater than 12.9 minutes. And the lowest risk of bleeding in the plots down below is when your MA is greater than 55 millimeters and your fibrinogen is greater than 345. So I think a really terrific example of using the test that we've had available for decades and using it and finding new information and how we can apply this to patients today. I think this is terrific. So I think what we all want to see happen when we do this, though, is here what Brian Bridges' group showed in Nashville. This is a bit older study now, but I think it's still one of the best ones out there. And what he showed was by using an intensive anticoagulation protocol that included anti-10A, that included thromboelastogram, included TAG variables, compared his previous number of years of 200 patients to 150 years of after, that if you compare using more intensive protocols before and after, what he showed was that hemorrhagic complications, so bleeding events are less, thrombotic complications are less, the use of all blood products, including packed blood cells, fresh frozen plasma, and platelets are all less, and the most important thing is that survival is higher. So this, I think, is an example of what we all want to achieve by using or changing or altering or being better at how we monitor anticoagulation in our own centers. We tried to do the same thing in a single center study looking at us versus Michigan, but we didn't have enough patients and we weren't able to show, wasn't powered to show the same outcome that Brian just showed in the previous one, but I would definitely like to try again with more centers. So in summary, I think bleeding and thrombotic complications have, as I said at the beginning, have significant impact on clinical outcomes, and it's why we have to be, I think, so aggressive looking for them and trying to prevent them. The classic approach to ECLS anticoagulation, I think, is no longer enough by itself, and there are novel monitoring tests available. These novel options include APT, TAG, ROTEM, and anti-10A. We're going to hear about anti-10A coming up, and there's lots of information, I think, for us to move forward with. I encourage you to consult the EuroELSO anticoagulation guideline at elso.org, as we will be updating that from time to time and year to year. Thank you very much.
Thank you very much, Laurance. That was very insightful. I've got a quick question. Maybe Victoria can set up a poll. I was just wondering in the audience what type of tests people are now using primarily to titrate their heparin. Please, if you can answer this question. It's a very basic and simple one. And then we will listen to the talk by Ariane about the anti-10A. And then maybe at the end, we'll see if these two talks have changed your opinion. So if people would like to fill this out, gives us a 30-40 seconds to get the results back, and then we can see what everybody's using across the globe. There's 175 people involved, so I'm expecting some answers. $200 people. Are the results rolling in, Victoria? Has everybody voted? Yes. So, oh, it's very, look at that. A quarter ACT, a quarter APTT, a quarter anti-10A, and a quarter uses a combination. This is interesting. This is not what I expected. Okay, thank you very much, Victoria. We'll talk about this later. So the next speaker who is going to talk to us about anti-10A is Ariane Willems. Ariane, the floor is yours.
Thank you, Pepe.
Yes.
Do you see my slides?
Yes, we do.
Okay. Sorry. So it's my pleasure to be invited by Pepe Roeleveld on behalf of the EuroELSO to present on anti-10A guided anticoagulation on ECMO. I have no conflicts of interest. However, I have to disclose that I'm not an expert of anti-10A assays. During the next 15 to 20 minutes, I will just share my experience as a clinician at the bedside using the anti-10A for monitoring anticoagulation with unfractionated heparin in neonates and children on ECMO. First, I would like to present you a quick reminder of the basics of the anti-10A assay. The anti-10A assay is a direct measurement of heparin activity through a chromogenic procedure and a mixture of factor 10A plus a specific chromogenic substrate is added to the plasma of the patient. In the plasma of the patients, you have heparin binded to endogenous antithrombin, and this factor 10A, activated factor 10A, will bind to this complex. The residual non-inhibited factor 10A cleaves the chromogenic substrate that releases a chromophore that is optically red, and the amount of chromophore is inversely proportional to the heparin concentration. So those are the basics of the anti-10A assay. There are some pitfalls using the anti-10A. I would like to put in light in the different slides that are following. First, the target range of 0.3 to 0.7 units per milliliter is not based on solid evidence. It is based on adult studies where patients receive unfractionated heparin for venous thromboembolism, and the results of these studies are extrapolated to children based on the APTT and on the protamine titration test. There are no randomized control trials comparing different thresholds of anti-10A in children on ECMO. There are only 2 retrospective observational studies, and my presentation was frozen. Sorry for that. There are only 2 retrospective observational studies showing that there's a difference between patients in anti-factor 10A levels in patients with no complication, the green line, compared to patients with circuit clotting. But as you see, the threshold and targets at lower than those used in children on ECMO. A second study by Katie Moynihan shows also that there was a statistically significant difference in anti-10A value between children with complication, thrombotic bleeding complications, and mortality compared to those who did not. Anti-10A assays has a lot of limitations. The first one is that the heparin activity measured by the different assay is variable. This is a study by the group of Paul Monagle and Vera Ignatovic. It's a study comparing 3 different assays in children. And as you see, there are major differences in anti-10A between the different assays, and those differences are more pronounced in the high heparin dosing regimens compared to the lower one. Those differences are related to 2 problems. First, some assays have and others have no exogenous antithrombin effect. This is also called the antithrombin effect. And assay can have presence or absence of additional dextran sulfate. What is the antithrombin effect? So anti-10A assays can be performed with or without addition of exogenous antithrombin. The rationale for adding exogenous antithrombin to anti-10A assays is to standardize this antithrombin effect. And in this case, the assay relies on the presence of exogenous antithrombin, and it reflects the heparin concentration present in the sample. Some people considered it as an artificial measurement that doesn't reflect the real in vivo anticoagulant effect of the assay. And assays that include exogenous antithrombin supplementation may overestimate the in vivo efficacy in case of low plasma antithrombin activity. And as you know, it's very frequent in children on ECMO and in critically ill children. So it's a real issue, the presence or not of exogenous antithrombin in the anti-10A assays. Anti-10A assays without exogenous antithrombin relies on the presence on the endogenous anti-10A levels, and so the antithrombin levels of the patients, and those low in the case of low endogenous antithrombin, you have an underestimation of the anti-10A levels, not the anti-10A activity, but anti-10A levels. And there's a risk of underestimation of the heparin concentration, leading to over-heparinization and an increased risk of bleeding. I try to compare those two ways of doing anti-10A assays. With addition of exogenous antithrombin, you have the real the in vitro unfractionated heparin concentration. When you don't add exogenous antithrombin, you have a reflection of functional heparin activity in the patient. When the patient antithrombin level is lower than 80%, you can have huge difference between those type of assays. As I said, another problem and limitation of the anti-10A assay is that some anti-10A assays are performed with or without the addition of dextrane sulfate. So in vivo, heparin binds to plasma proteins, and dextrane sulfate the addition of dextrane sulfate to the assay aim to reduce the influence of those heparin binding proteins. So the use of assays containing dextrane sulfate can lead to a significant overestimation of the heparin activity, but particularly in patients where where high doses of unfractionated heparin are administered. Another problem, so I show you that different assays yield different anti-10A results, but there's not only a problem of assays. If you use that, this is a study in adult patients. Nevertheless, it's the same in children. If you use the same assay on a different instrument, so the technique is different, you also have different results. So in conclusion, different assays yield different results, and so anti-10As between centers and between institutions are not always comparable. Another huge limitation of anti-10A assay is when there's a presence of chromogenic molecules in the plasma of the patients. Children and neonates, infants, and children on ECMO have increased levels of free hemoglobin due to hemolysis and bilirubin in their plasma. And this is a study in children on ECMO where you see the effect of those molecules on the measured level of heparin activity. And in the presence of both molecules, you have an underestimation of measured heparin activity with a risk of giving more heparin to the patient and an increased risk of bleeding. Another problem is that most of the time you have the presence of both molecules, and both have a synergistic effect, so a further underestimation of the measured heparin activity. Another molecule that influences the accuracy of the anti-10A assay is the presence of high triglyceride in the patient plasma. So unfractionated heparin has an effect on different coagulation factor, and not only on factor 10A, but also on factor 2A. This is a study where you see the ratio of anti-10A against anti-2A, and you see that there is a difference in unfractionated heparin effect on factor 2 and factor 10. There is a difference. There is an age difference. So children, heparin, sorry, inhibits differently anti-10A, 10A, factor 10A and factor 2, depending on age, but also depending on the heparin dose. This means that in some situations, your anti-10A assay can underestimate the global anticoagulant effect of unfractionated heparin. If you have a patient where heparin has an important effect on factor 2A, you can underestimate the global anticoagulant effect of heparin with your anti-10A assay. So the first question, and Laurance already answered the question, is there a correlation between the heparin dose you are administering to the patient and the anti-10A assay? And here, this is a meta-analysis published in 2019 that confirms the conclusion of a lot of studies that the anti-10A assay has the strongest correlation with the heparin dose in children undergoing ECMO if you compare it to ACT APTT. The second question is to know if this correlation between anti-10A also improves outcomes compared to the other tests. And this is a meta-analysis published in 2020. It is a meta-analysis in children and adults, but we had no studies comparing both anti-10A based anticoagulation strategies with time to clot assays in adults, so the results are only for children. And as you see, in children, an anti-10A based anticoagulation strategy decreases bleeding events and mortality rate without increasing thrombotic events. Two studies looked at the current practice of monitoring unfractionated heparin. The first study was published by Melania Bembea and Gail Annich in 2013, and Karin Osment repeated with Melania Bembea the study, and this study was published very recently. And what you see is that over the year there's a shift towards anti-10A monitoring, but also that anti-10A monitoring is used in conjunction with time to clot assays such as ACT and TEG and ROTEM. Furthermore, with time, more centers also monitor antithrombin activity and free hemoglobin levels. The recent study published by Caroline Osment also shows that the most common heparin monitoring combinations used in ECMO centers are anti-10A with ACT. So I would like to conclude that the anti-10A assay reflects the heparin the heparin activity in the plasma of patients, and has two huge advantages. Is that it correlates well with the heparin dose administered to the patient, and that it's possible that we can have better outcomes with these assays than with time to clot assays. However, the anti-10A assays has also some limitations. Therefore, it's important to understand the anti-assay that is used in your institution before considering it for monitoring anticoagulation with heparin in children on ECMO. Second, it's important to know that the anti-10A assay is only a representation of a very small piece of the complex puzzle of the coagulation and anticoagulation of patients on ECMO. Therefore, I would consider a combination of assays to better understand the whole coagulation status of the patients. And finally, it's very important also to observe what happens in your patients and in the circuit. To my point of view, the best test remains what you see in your patients and in the circuits. Thank you for your attention. I cannot end this presentation without introducing the pediatric ECMO anticoagulation collaborative led by Peter Alexander and Jen Musinski, who is developing a consensus-based clinical practice guideline for anticoagulation on ECMO in children. The recommendations are now on their third round of voting, and the publications are expected for the end of this year.
Fantastic. Ariane, thank you. I would like to invite the Laurance and Gail also to maybe reveal themselves virtually, so we can start a panel discussion. And while they do so, I would like to ask Victoria to put up a second poll, please. And my question this time is, after hearing the two speakers, what do you now think is the best anticoagulation monitoring test in children? And before this, we asked you, what are you currently doing? And it was very divided, 25% ACT, APTT, anti-10A and a combination, and nobody answered a tag. But now that you heard the two speakers, what do you think is the best anticoagulation monitoring test or tests in children? People would like to vote on this, and then we can take it from there. I've had some interesting questions coming in based on the talks, and also before the actual webinar started, people were sending in questions, which is great. I really love it. So thank you all for that. And if you have any questions, please send them in to me now. And like I said, I will try to amalgamate them and relay them towards the speakers. There's two questions that I can answer. And they are the same actually, and that is, two people are asking if this meeting will be made public afterwards, and the answer is yes. They will be shown probably as of tomorrow on the EuroELSO.net/webinar link, or on the website, or on YouTube even. So people will be able to look back and listen again and look at the two great presentations that we just had. So, Victoria, do we have the results? A combination. Fantastic. Now, let me not comment on that, but let me ask Gail Annich, who's just joined us. Can we show?
Hi, Peter.
Hi, Gail. How are you? Thanks for joining us today, this morning for you, and this afternoon for us here in Europe. You've heard the two speakers, Ariane and Laurent, and we've asked people what they were using to monitor their anticoagulation, and in the beginning of the session, and now we've asked it again, and people feel now that a combination of tests is probably the best way to go. And so I would put it out to you guys in the panel. What do you think is the best anticoagulation monitoring strategy? What do you use, and what do you think should be the way to go?
So I've had the opportunity of living through all of this. You guys are all way younger than me, so this is kind of cool. So I've lived from using it since, you know, the early 90s, what we used to do, to what we're doing now. And so at a time where we didn't have all this really funky, great testing, we had to deal with it, ACT, which was in fact designed really for cardiopulmonary bypass, because we didn't have other intricate tests to tell us the heparin effect, but we needed to know how long it took for the blood to clot. And, you know, cardiothoracic surgeons said if an ACT was around 400, that was awesome, because they didn't want it to clot too fast before they did the cardiopulmonary bypass. But you know, that history has changed from that first red book that we wrote, and I had the privilege of writing with Hank Edmonds, to something now where, you know, it's become a lot more intricate. I think Patty Massicott started that with a lot of her work for VADS and other things, and we had to figure out how to not clot off VADS in children. So the smaller the devices got, the more intricate we had to get. You know, I still think there are places for all of these tests, including ACT, but I think you have to be very careful in what you choose to compare and not compare. I think you have to understand your anticoagulant, and I think that's what this latest sort of survey that was done by Melania, to repeat the one that we did early on, was to show that you can't rely on one single test. It really is what Ariane presented in her final slide, what you see clinically, what you see the circuit doing, and almost is as a discussion of customization per patient. So using something to start with, but then being able to customize. And so some people may have the resources to do tags and ROTEMs all the time on their patients, but others may not. So what do they use as a whole blood test? So I put that out there to the panel. But it's how you use it. I don't think you can compare an ACT or a TAG or a ROTEM to an APTT or an anti-10A, because I think one of them is checking or assessing anticoagulant effect. The same thing is relevant for direct thrombin inhibitors, if you want to get into it, because it's what is that anticoagulant doing? That's the plasma test. And the other side of it is the whole blood testing, which is what's happening to my patient clinically. So I think it's always interesting to know what the anti-10A is, and using it as your guidance is where you want things are, because we know from experience it's good to have it between 0.3 and 0.7. But then understanding what's happening to my patient. Should they have a bleed? Should they start to develop fibrinolysis? What is going to happen to them? And having that other understanding. So I almost liken the ACT like a physical exam of the blood at bedside, just to give you that sense. And so if you don't have the resource to run multiple tags and other things, you do have the ability just to assess that. And therefore, we have to pull away from it being done every hour to something where we say we're going to watch this trend over time and get a sense of what's going on. So I love the combo. If I could have voted, I would have voted combo both times. But that's kind of where I have evolved to, or grown up to, coming from a center that only did ACTs to going to a center that does all of the panel as per what you know, Maureen Andrews and Patty Massicott had developed early on.
Thanks, Gail. Laurance, do you what are your thoughts? I think you have to click unmute.
to this as well. Can you hear me as well? Okay.
We can hear you now. Yeah, thanks.
Good. Okay, thank you. Sorry, I forgot to press unmute myself. So sorry. Thanks for doing that for me, Victoria. Yeah, I would say again, almost experiencing this as long as Gail has. And she's very kind to say that I'm younger than her, and I barely am. But you know, I think things have evolved and changed, and I think what you have available is really important. And it's sort of, you know, when we go to teach courses in some countries in South America, you know, the equipment that's there is different, and how we teach the cannulations and the different cannulas and things are different. And it's the same with anticoagulation monitoring. And like Gail said, we haven't even got to the direct thrombin inhibitors, which, by the way, plug for this, I think is the anticoagulant of the future for all ECLS. Someday we won't be using heparin at all. And I hope that day is getting closer and closer with the studies that we're doing. But living in the world we're living in right now, I agree. I think we need a combination of tests. I think we need a whole blood test like the ACT, or now the TEG, which is becoming more reborn again, and new understanding of how to use it and what it can give you. And I think that study from Boston that just came out in the last month is a terrific one to show what's possible and how accurate that can be as compared to some of the other tests. ACT is a terrific whole blood test, as Gail said, to know what's happening with your patient at that time. But you have to understand the limitations of those tests. And likewise, I think it's terrific to also have to augment and to get, I think, a more accurate representation of actual unfractionated heparin anticoagulation, a test like the anti-10A, which, as we have seen, has been shown to be more accurate and a better correlate to heparin dose and clinical activity, and to be more reliable. And so we do use all of those things, but as I said, we use them in a combination, and we're hoping to use things like TEG and ROTIM more than we have in the past. I know lots of centers probably have those use more than I think we at our center do currently, and I think we're hoping to sort of evolve along with everybody else. But certainly a whole blood test and a plasma test. Now, some people prefer the APTT to the anti-10A. I know lots of adult centers, especially when I go, prefer the APTT. That's a good test. There's lots of good studies now coming out. There's point of care testing available. So as long as you understand the test and you understand how to use it in your protocol, in your center, I think that's very helpful. But I think just doing what we used to do back 20 years ago, following the ACT, and sometimes things are good and sometimes things are bad, and you're questioning what am I doing? I think those days are long gone and behind us, but it was necessary to go through that to get, I think, to where we are now.
Thanks, Laurance. I was happy with the result as well. That I think a combination of tests is what you should do. And like you both said, you have to understand your test, because if you just compare tests with another, they sometimes give conflicting results that, if you don't really think about it properly, that can put you in the wrong path. There are some questions about this in the chat function on this. And for instance, somebody is asking if you have, you can see a conflicting result from an APTT and an anti-10A, where you sometimes see that your APTT is very high and your anti-10A is low. And people are asking how this can be explained. My question to them is you probably look at more than just an APTT. You look at DT as well. That's what I would do. But can either of you explain why there can be a difference between an anti-10A and an APTT? If you just look at those numbers, what are we missing then? Maybe Ariane, you can comment on this, because we see this quite often. We've had this discussion in our unit with people.
Yes, thank you, Pete. But it's very difficult. I think that's what Laurance and Gail already said. It's important to know the limitation of the test, and to know that an APTT in children can be prolonged for different reasons. There are first pre-analytical reasons, because the way you are drawing blood, or if you are drawing blood, you have a little bit of heparin in your line, you can have a prolonged APTT. So you can have at each moment of the analysis of your APTT a different a different result. Another problem with the APTT is that, as for anti-10A assays, there are a lot of APTT assays who are not looking at the same factors, coagulation factors quantities. And in children, we know, and in very sick children, you can have circulating lupus anticoagulants who is also influencing your APTT. So that's why it's important in your center to understand which type of assay you are using for anti-10A and APTT. And then to, when you have conflicting results, the most important is to try to understand and to combine different tests to see where the problem can be. So as you say, Peter, to look at a PTT, but you can also look at you can use a different coagulation monitorings.
Yeah, so maybe Gail wants to say something. Is that correct?
So, you know, I think the most interesting thing I find when we look at anticoagulation and ECMO is that we look at these tests and we try to peg on them. We look, okay, this anti-10A must be this, but the APT doesn't correlate. And yet, as intensivists, you know, if a creatinine is out of whack with a urea, we go, yeah, that doesn't make sense. So we start to look at it a little more. We try to understand it. We might repeat the test. We might look at other things. If the sodium value doesn't fit with the, you know, other things, or the chloride's really high, but then the next one isn't, I'm not saying repeat all the blood tests all the time, but I think that sometimes, you know, in anticoagulation and ECMO, and I have fallen into the same rabbit hole, we kind of run down it and we say, oh, this is abnormal and this doesn't fit. And we don't try to explain that sometimes, when really what we need to do is step back and go, okay, so why are these so abnormal? Why are these different? It could be user error, right? I mean, in Michigan, we had to reassess our, when we were doing ACTs, we had to get a new machine. We had to reassess how to do it. And they would not let the physicians draw the ACTs because we suck at it, right? So it's also user error. And if you have newer people drawing for any of these tests that we are doing now, it can be a lot of those things. It could be that, you know, we end up contaminating the line with an arterial line that has heparin in it. Obviously, in an ECMO patient, we have to have an appropriate draw and know what we're drawing and have a sense of what's happening. And, you know, we assume that the lab does the test all properly as well. In Michigan and even here at Sick Kids, we fell into just not quickly enough realizing that our standards had changed where APTT was, because our thromboplastin lot number changed. And you have to, that kind of stuff needs to be able to come through and not fall down that rabbit hole on those specific numbers all the time. We had assumed that we were continually contaminating an arterial line in a non-ECMO patient. I was just thinking about this, and his APTT was high all the time, and he had a subdural bleed. And we just assumed we're just contaminating it with our art line, you know, he's going to get better. And then he had another bleed. And so then we kind of looked at it, and he actually got diagnosed with type B hemophilia. So, you know, good learning for someone who's been at this for a long time. It only happened 3 years ago. I mean, we were all there, you know, these supposed experts in the field, but just focusing or relaying it to something. And so when you look at those two numbers, you have to have an understanding of what you're looking at. It's possible that your anti-10A is in good range and your APT is completely out of whack, or you know, it's possible how the lab was drawn. But normally the APTT being out of whack relies on a lot of other factors than just the anti-10A, just in the 10A. And so I think that can also relate to the discrepancies, and ECMO circuits gobble up all kinds of protein. So that would be, I don't know that it answers anybody's question on that, but I would take the approach to look at it and then try to figure it out like you do as an intensivist for any other reasons when they're not on ECMO and the lab results don't make sense.
I think that's a great point, Gail. I think we have to be aware that we don't fall into a trap of thinking that there's a patient on ECMO and he or she is on heparin, and we take one test and we just titrate the heparin. It's not that easy. The patient is sick. There's so much going on. The coagulation is out of whack. And if you have a very stable adult patient, yes, maybe an APTT alone in a stable phase is okay. But as soon as something else happens, it gets much more complicated, and you have to take all these things into account and not just follow a little protocol that says with this number of APTT you have to titrate the heparin this or that. There's much more going on. But I do, not that I'm saying that you don't need a protocol, I do feel really that you need a protocol. And we've had some comments here saying that from experienced people across the globe saying that they've had a very good experience with implementing a protocol, bedside management by the nurses, by the ECMO specialists, and educate them well, and that they have felt and seen a great improvement in anticoagulation and less bleeding and less thrombosis if you keep it in a few people that are very much aware of what's going on. So I think that's what people should do: create a good protocol and teach your people. A few more basic questions, just more down to earth. People that are trying to, that maybe now considering to get into using an anti-10A. Some of people are sending in questions: how often do you do an anti-10A? And if you do an anti-10A, how and you change your heparin, how long before you do the next? Can we give some guidelines on that? Ariane, can you maybe say something about your anti-10A monitoring? What could people do?
So in Leiden, we are routinely measuring anti-10A 4 times a day. And I think when the patient is stable on heparin, you can decrease it, but that's how we started. And you have to be aware that when you change heparin administration, you have to wait for the result, and you don't have to control it too early, because otherwise you will underestimate the effect of your change or overestimate if you are decreasing the heparin. So the half I think we should consider that when you change your administration of heparin, you can control it 4 hours later based on the pharmacokinetic of heparin. So that's what I would propose. And sometimes we measure it more frequently, and as we all said, I think you have to combine it regularly with other assays.
Any comments, Laurent?
I would agree completely with what Ariane just said. We also measure it every 6 hours. We're kind of lucky we've been able to have that monitoring available in our center for more than 10 years. As Ariane said, once you change the dose, you really need to give it time to work up. So there's no point in you really do need to wait a good 4 hours to do that. In fact, often I'll just leave the test every 6 hours so we stay on track and not do extra tests in the middle. And usually we're making small changes and you're expecting small results. We're not making rapid changes. So that's one of the things. And I think the other thing is just sort of being aware of the type of anti-10A assay, because as Ariane said in her talk, I think we're not having the antithrombin in it is really important. And I think that tests that do have antithrombin in the assay are, I don't think, as reliable, and I think can cause some other trouble when you're sort of working with it. So I would just be careful for that.
Yeah, I think that's an important point to realize whether or not exogenous anti-10A, antithrombin has been added. And there's a few questions about that as well in the comment section. But also some people struggling with the idea that if we use anti-10A, does that really tell us anything about the coagulation status of the patient? So if I put it out there to you, say an anti-10A doesn't say anything about the coagulation status of the patient, what do you then say? Is that correct, incorrect, or is that just half of the story?
It measures the heparin activity and the effect of heparin on your coagulation, but it's a measure of the effect of heparin on activated factor 10A, but it says nothing on the rest of the coagulation. But factor 10A is an important coagulation factor within the coagulation cascade. I don't know if this answered the question.
Yeah, I think so. I see you nodding, Laurance. You agree? Yeah. Yeah. So,
yeah, I agree that.
Yeah. So, Ariane, you said that you can do the test with exogenous antithrombin and without. And you, in your slide, you mentioned that below 80% antithrombin, you can clearly see a difference in the results of the test. If you do the same test in the same patient with or without antithrombin, you'll get different results. So this could lead people to think, and this is we've gotten a few questions about this. Should we replace antithrombin in children on ECMO that are using heparin? And this is a huge debate, also in adults. And we haven't mentioned this yet here, but I think we do have to get into that a little bit at the moment. So what do you think, Ariane? Should we replace antithrombin regularly or above a certain level? And then we'll ask the other.
I don't know, because there is no evidence that you need to replace it. I know it was never replaced 10 years ago, and then there was a trend toward replace it regularly in patients. I don't think so. I don't think we should target normal values above 80%. That's my point of view. Some studies are showing that it may increase bleeding. But one thing I would like to add is that you also have to be aware on the way you give it, because a lot of centers give boluses of antithrombin and not continuous infusion, and this may have a huge impact on your heparin dose, but also on your anti-10A effects of heparin. And so when you are measuring anti-10A, you have to be aware of if you administered yes or no antithrombin before the assay, because it can also influence the assay, because you are giving a lot of antithrombin who will bind your heparin, and you will increase your heparin activity. So the test may be different. So those are a lot of limitations, but on the clinical point of view, for the moment, I cannot recommend for or against antithrombin supplementation in children on ECMO. What we do, we don't replace it in Leiden, and in other centers they replace it only when you have heparin resistance, when you have a very high dose of heparin. In small children, you administer or plasma or recombinant antithrombin to decrease the dose of heparin. But for the moment, I think we cannot recommend for or against with the literature we have.
Gail, Laurance, what do you think? I see Laurance nodding.
I would say that, if you think about it, it makes sense to replace it because you're consuming antithrombin, but sometimes what we think makes sense doesn't make sense in the patients. And I think we've gone through a phase of not even knowing that antithrombin was being depleted over the course of ECLS, but it certainly is consumed as you use therapeutic heparin. To then deciding, well, it's you give plasma, and maybe. And the plasma contains a very small amount of antithrombin, by the way, the normal plasma. So it only contains, it's 1 unit per mil, which is 100% the activity of adult plasma. So if you were giving, let's say, a therapeutic dose of antithrombin and you wanted to give, 50 units per kilo of antithrombin, you'd have to give an awful lot of plasma to give that same dose. So that when you give a dose of plasma, you really aren't giving that much antithrombin. But having said that, some antithrombin is better than no antithrombin if you have a problem with antithrombin. Now, there's been lots of studies that have showed that by maintaining a certain high level, like in neonates, like as Ariane said, above 80%, and you're giving lots of product. For us, we don't routinely replace it. We don't keep it at the antithrombin measure. But as Ariane said, if the heparin dose escalation starts going up and up and up, and the antithrombin level is coming down and down, then we will replace it. We do have, and it also depends on the type you have. We don't have recombinant in Canada, so we use the plasma-derived factor, and we drop the heparin dose by 25% when we do replace it. We probably end up replacing it once a week on some patients, once every 2 weeks in other patients, not never in other patients. So it really depends. The younger patients tend to consume it more. I think it is important to have it as an option when you have heparin resistance or when you have ineffective anticoagulation, but I don't think we can say right now that just replacing it and keeping it above a set level is worthwhile, and it might not even be safe depending on the amount of blood products that you get.
Gail, anything to add?
Yeah, I mean, I agree.
Disagree?
I agree. I agree with Ariane. 10 years ago, we weren't measuring it, and or even 15 years ago, we weren't measuring it. And if you wanted to measure it, you had to sell your firstborn at Michigan in order to do that. And I only have one kid, so I never measured it there. That was kind of the way it happened, but it did become a trend. And whenever we can create new products and isolates, and we're trying to reduce volume of blood products and trying to not use as many of the human derived blood products, because we know those exposures can be dangerous. And there's no doubt we have to always pay attention to that and try to strive for better. I think the antithrombin level is an important thing to consider. And I agree with Laurent that, the answer is that we can't, we can't really replace it with FFP, but maybe, in some of these heparin resistant type of patients, in fact, they have a complete dysregulation of a lot of their clotting factors. And if we start to do the more specific testing now on circuitry and what binds to circuitry, we know that factor VIII loves the circuit. We know fibrinogen loves the circuit. We know a lot of different proteins that are involved in our coagulation components of clotting and also in anticoagulation bind to the circuitry. And so maybe we're not really replacing the antithrombin in those instances where we're trying to have the heparin have more effect, but we're more balancing the cascade when we're using FFP. And I will say my default when heparin wasn't very effectual in neonates, when we just used ACT in Michigan, I would use some FFP for 24 hours. I'd give them some fresh FFP for our time period. I wouldn't run it prolonged over time because then its efficacy is good. And then I got into my normal range of heparin and I said, okay, well, that's done. I feel good. But it wasn't very specific. It sounds like I'm doing this in the back of my garage somewhere rather than in a lab. But as we started to understand more and we could test for it. So I think that antithrombin does have a place in very specific patients, like Laurence is saying, but I do worry if you're using it as a standard routine that you can really unbalance things that you're trying to balance in managing your ECMO patient. And there are dangers in giving these products, even if they're the recombinant ones or not, in terms of the degradation and how normal antithrombin starts to metabolize into latent antithrombin, which is actually procoagulant. And there's been some studies out by Wong, who's no longer in Seattle, but who demonstrated that as one of the other things that can happen. And you can actually have some clot formation. And so I think with anything that you choose to do, is it a routine or is it something that you look at? We measure it, but we don't act upon it unless we feel it's having effect on what our circuit's looking like or in our patient. And I don't know that that's a great answer because I don't know my patients who aren't on ECMO what their antithrombin levels are. So I don't tend to measure them, but they could be somewhere similar in a critically ill patient, and maybe there's a reason for that.
Yeah, so I think it's fair to say that there are no clear cutoffs in this at all, not for an anti-10A, not for an APTT, not for an antithrombin, and it's all the time it's a combination of factors, and your patient bleeding, not bleeding, having a procedure, not having a procedure, being infected or with diffuse intravascular coagulation or with infection. There's so many factors affecting the coagulation in the patients that makes this so difficult, and there are no, to my opinion, no clear-cut values as to you have to do this at that time. Agree? I think we probably all agree on this. But that makes it so difficult, and that's why this is so insightful. But on the other hand, yeah, we don't have clear answers to all the questions either. That can be problematic. I have a question. Let's go somewhere else.
I would just reiterate, Peter, that what some of the audience had responded to say you have a set protocol or a guideline is really what is crucial. And understanding when you're going to use antithrombin, understanding how you're going to use your APTT, if you're going to use it, when you're going to do your TEG and how frequently, those types of things. I think that those are really important things to remember. You have to start with something. You have to have a protocol. You have to have a sense of who you're going to call, who you're going to discuss it with, just like you do for anything else. We don't just sort of not have a protocol. So I think that that's imperative, is a protocol, and how it looks for each center is going to be different. But I think that's the customization. And if we can, as ELSO, provide a good guidance of how to do it, not just sort of a menu of 20,000 different choices, but actually some examples of how to create your own customized protocol, I think that that's where we would do the best. But each center will be different, but has to have a protocol. I would say that would be my biggest.
I totally agree, and I'm assuming that people do have a protocol. I'm hoping they do, but that's a very important comment there, Gail. Thank you. I think we're going to round this off in the next 10 minutes or so, and I've got a few questions left. There are many questions still out there, but some more maybe practical questions. Let's say we have a patient who also has low platelets and is bleeding, and we provide platelets. How do giving platelets, how does that affect your anticoagulation measurements? And what do you do? Do you increase heparin, or I've seen that in a few centers, or do you just wait and test it after a certain while? What do you guys do when you give platelets? How does this affect your anticoagulation strategy? Laurance, can I start with you, please?
Sure. Well, it doesn't change anything right away, because remember, usually when we're giving these factors, it's because they are bleeding, and so we want to wait to see what happens, as Ariane and Gail said, what's happening with the patient, what's happening with the circuit. And I think any intervention, you want to wait to see how things happen. And so we don't routinely adjust the level of anticoagulation after giving platelets. We try to, give them so that we're not causing any trouble to the circuit. In the old days, in the older circuits, that used to be a problem. With the novel circuitry, that certainly doesn't appear to be as much of a concern. So no, I think it's a matter, especially when you have somebody that's bleeding. And remember, bleeding is the #1 complication, the #1 correlate to poor outcome. And so anything we can do to minimize bleeding, I think, is extremely important. And so if you have a bleeding patient and you find that they need platelets or they need another blood product, I would just give that blood product and wait and see what happens as your regular protocol sort of takes over. I wouldn't make any changes to the anticoagulation, other than perhaps you've already reduced the anticoagulation because of the bleeding, and sometimes that's not enough of a treatment.
And if a patient is not bleeding, is there a certain platelet level that you target?
It depends, yes, and it's all by protocol. And if you look in the if you look in the ELSO guidelines, or if you look in the textbook chapters for blood products, there's great guidelines. We've adjusted ours to be sort of a little bit specific, but we tend to sort of go by age. And so, for instance, we keep platelets for the most part above 50,000 in most patients. If we have a bleeding neonate, we'll even keep it higher than 50,000. But certainly most of our pediatric patients, most of our certain adolescent patients will be sort of 50 is sort of the low, where we'll be giving platelets prior to there being bleeding. But we also have patients that are difficult matches, and as the long runs go on, and we're you know, the older patients, they're not bleeding, and we're hanging in there at 20 or 10 or whatever it is, because they're a challenging patient to transfuse. And so I think there isn't a specific number, but just an idea of a number. And I think back where the days where everybody had to be above 100,000, that's not the same. I think there are very few patients where we're transfusing to that level, but certainly there are some patients where we will, like a neonate that's having significant bleeding, we'll be getting the platelets above 100,000.
Gail, is any different for you?
Oh, it's way different than it used to be, because 100,000 was it, but it was with those old beastie circuits, right, that allowed us to just be able to do ECMO. And so the consumption was pretty pronounced there, and they stuck to those solid silicone membranes like anybody's business. But, you know, I think, you know, I'm glad I'm still learning 25 years into this practice things. You know, the neonates are the bane of my existence because they just never behave like they should. You think that they're somewhat immune naive, and yet, you know, if you put a septic neonate on, they just gobble those platelets sometimes like nobody's business, and you're just like, what am I going to do? And yet, if you over transfuse with the platelets, you've just sent a big old source of more inflammation into these kids, and they can get really much sicker by continually fueling this fire by giving more platelets. But you know, it's kind of like two cars driving towards each other. When do you say, okay, I need to give in and give some platelets? Is it 20,000, 25,000? We know that neonates can bleed in their head, and just because, you know, we're trying to hold off giving platelets, when is the time not to? But I think that the era of the 100,000 is gone. I think in the bleeding patient, that's a different plan. But I think that we just have to be aware that platelets, regardless of them being just a fragment of a cell, are just, if you have very bad inflammation, you have a very challenging patient, you can fuel that fire with more and more acceleration of that. And, you know, I've personally seen it, and I don't have the answer. I don't know what it would be. Those patients are that 10%. The other 90% that follow your protocol are awesome, but at 10% that make your hair go white, and it will continue to do that. And I don't have an answer for that. And I don't know if it's the right answer to say, yeah, if it goes below 20,000, I'm going to give this baby platelets. I don't care, because, you know, it's below 20,000, they're still really sick. Or maybe do I just hold on? But, you know, when the next value comes back at 6,000, you're like, well, that was crazy. Probably should have given some platelets. But do I know that giving those platelets is making a difference either? I don't. I just know that, you know, 6,000 is a little beyond my threshold point, and I'm happy to push things. But I know a lot of centers are doing, you know, even CV surgery on patients and being able to hold them at 25,000. That's fine. So it is how your unit works. It is how you monitor things, and it is how you feel confident in things. And we're not always going to make the right decision. I think the platelets is something we have never really unraveled with ECMO and gotten a good sense of. There's a few groups doing it and targeting platelets rather than the cascade for anticoagulation like they do in Australia. And I think that and the research that I've done over the 20 years with Bartlett and crew pushes me more towards thinking that might be a better option. Just putting it out there.
Yeah, very interesting. There's still a lot to learn, isn't there? Just going from one practical side to another, what if we do an intervention on a patient? Let's say it is not a bleeding patient, but we close a diaphragm, a diaphragmatic hernia, or we do some other intervention, a cardiac catheter. And what do you do with heparin? Do you stop heparin? And if you stop heparin, do we then have to, when do you restart it again, is one of the questions I'm getting. So you've done an intervention, you stopped it, and then what? Bolus? But then what do you think? Can anybody comment?
I guess I will. We tend to, as you said, for most sort of procedures where you think there's going to be bleeding, whether that's, you know, a thoracotomy in a really sick, you know, we've had those patients that have had to have that in the ICU all the way down to something simple like a tracheostomy. You know, we do hold the heparin. Usually we hold it for about a couple of hours prior to the procedure and then about 4 to 6 hours after. We usually don't re-bolus, but restart at the therapeutic level that we were at before, the same dose, except that we have had some patients that have had significant, if the reason we're doing a procedure is because they're bleeding, sometimes we've had to hold the heparin for longer. So we've had patients where we've been off 12 to 24 hours after a procedure, like opening someone's chest, before we're restarting the heparin. And sometimes we'll start at the dose we were on before, or sometimes we might even start at low, about half the dose, wait 6 hours to eventually get up to a therapeutic level. It's different in every patient. I know that, again, we keep saying that, but there's not any specific answer, but certainly it's possible. And as Gail said, the beast of circuits that we had 20 years ago, you couldn't do that. I mean, you couldn't stop the heparin for an hour and the whole circuit would clot off, yet the patient's bleeding to death. And so I think people that are doing ECMO now are so lucky because the equipment is so much better. And so the novel circuitry, the coated cannulas, the novel centrifugal pumps, the polymethylpentene oxygenators, like these circuits don't have the same consumption. They don't have the same need for really, really high levels of heparin anticoagulation. And so what was unheard of, you know, 10 or 20 years ago, decreasing or reducing or holding heparin for hours at a time is now very possible and much more useful and safe.
In all children, or do you reserve that for the older children withholding heparin?
Oh, in young children, old children, all of them for a period of time around the procedure for sure.
Yeah. Well, thank you three for a very, very interesting talk and discussion. And there's many more questions, and there's a lot more to talk about this subject, and there's a lot to learn. And we can continue this hopefully in the future, and possibly at the EuroELSO conference in May. So again, I want to thank all the three speakers for joining us today, for sharing your experience and your wisdom. And I hope people have learned and gained an insight into this difficult topic of anticoagulation. So thank you very much. Finally, I want to finish this off by Victoria. Can you show the next slide, please? There's two more things coming up. One is the EuroELSO conference that I've talked about, and then the next webinar, yes, is going to be by Leen Verkaams, the perfusionist from Belgium, about the burden of the ECMO circuit. And I all invite you to join her during that webinar. And again, this webinar can be, and all the webinars can be seen back and reviewed at the euroelso.net/webinars site for you all to see and enjoy. Thank you all for your attention. Thank you guys for being on the panel, and we'll see you all at a later date. Thank you all.
Thank you.
Thanks, everybody. Looking forward to doing this in person someday.
That would be great, guys.
Yes.